Hello, how are you? This is Dr. Rehab Director here. Glad to see you join me again for another video. And today we're going to talk a little bit about using a carrot stick for, some moderate to severe hand contractures. Um, in a long-term care facility, it's very common to have folks who have had some sort of neurological condition or injury, whether it's a stroke, um, brain injury, some sort of spinal cord injury, um, and some sort of degenerative neurological condition like Parkinson's, for example, or multiple sclerosis. Whatever the reason is for it. For people who eventually have limited strength or high tone in their hands, immobile due to this lack of movement, actively or passively, sometimes due to the tone that the person may have, the rigidity, the spasticity, depending what's going on with them. The hand will start to close up, and without some sort of barrier, without that range of motion consistently, daily, it will close up all the way. With severe contractures in a long-term care facility, it's common to see that people sometimes, either because of the increased tone, their hand can be in a position similar to this. It's just a closed position. This is pretty severe. Some people will be fisted all the way. I'm one that I try to avoid splints as much as possible. I really try to deal with if the person can range their own hand, do self-range of motion, or they can do somewhat active assist, or if they have a caregiver or a staff member that can perform that range of motion. I'd rather go that route. I'm big on the less equipment we need to use, then that's the route I want to take. However, there's times when you're gonna need that equipment because maybe you don't the person can't do the self-range of motion, or you don't have the personnel to do that, or even sometimes with the right people in place and the right mechanisms in place, because of the tone that the person has, you need some sort of protection or barrier to keep that maximum range available. Now, keep in mind that any type of device you use, even if it's a dynamic device, without somebody or the person themselves ranging themselves, you can contract in that position. So if we were to give somebody a splint and keep them in this position because it keeps the hand open and it doesn't close, if that person themselves isn't ranging themselves, or if somebody else isn't doing that for them, their hand will freeze in this position. Okay, the orthotic devices are meant to kind of assist in maintaining the range of motion, but there's still a need for personnel, staff, family member, or someone, or the individual themselves to maintain that range of motion. But from just the hand and arm point of view, and what that hand can do in this position, there's not much they can do. Some people can use their hand as a stabilizer, like maybe they might hold on to a shirt while they button it in this way and stabilize it, or they might grab something and hold it. But without that dexterity and range of motion of the hand, it's very limited. So even if you have somebody who's higher functioning with that type of hand, without being able to open it or definitely manipulate or coordinate the movement, there's limited function to it. For somebody who's that severely contracted, sometimes what we're looking at, based on the fact that most of the time they're not having a lot of movement overall and they're not using it functionally, or because of how severely they're impaired, the cognition is just not available to help them relearn or to understand what is going on. So you're looking at very fundamental parts or fundamental treatments for that. Ideally, if you look at this hand, you're trying to reopen it. Sometimes because of the severity, you're not going to take this hand and bring it back up to a full open hand based on how severe that is. If somebody's in this position because of the tone, but you stretch them and you can get it open, that's a different situation. I'm talking about the person who has a hand like this, and when you try to move those limbs, they're just not going anywhere. And you can tell it's a pretty hard field. Sometimes, depending how long it's been that way, the joints are deformed, and maybe they have some ulnar drift deformities, ulnar deviation deformities to begin with, and it's severe because of RA or other type of arthritic conditions. And sometimes the bones themselves are shifted, and it's not appropriate to try and physically open that. Sometimes in certain individuals there's surgical interventions and things that are a little bit more elaborate, but from the conservative standpoint, we're looking at just being able to, open the hand enough where a caregiver can perform hygiene. Um, I don't know if you ever had the experience of seeing somebody in that condition, but if somebody's not getting in there on a daily basis, you will smell it. It has a very distinct smell. So hygiene is super important. I mean, at all times, but specifically with somebody who, whatever limb they have is in a position where it's not going through the full arc as it usually would. So you're trying to open it up to allow the caregiver to provide that hygiene, to avoid the nails digging into the palm, to be able to perform nail care and nail hygiene so those nails don't dig in there, and obviously to prevent further contraction of the hand. Even if the hand is not functional for the person, you want to maintain as much range of motion as possible to allow those things and to give them a more normal looking hand. Once somebody's been so far gone where it's in this position, you're trying to minimize that now at this point and get them into a little bit of a more open type of hand. There's different orthotics you can use for that, and people have different things in mind, and some people get very creative. But what we'll talk about today is a carrot stick. Okay, this one's made by Ally Man. I think that got it out from Performance Health. They tend to have a lot of good products, and I use them. Obviously, they're not paying for this video, but just I throw them out there because I think that they have been pretty good with what they provide. But a carrot stick here could be from any other company as well. They all pretty much look the same. And one of the things about this carrot stick is that it's really good for that person with that pretty severe hand contracture where it's kind of hard to get a palm guard in there because it's hard to loop the thumb, or it might be hard to get anything else in there, another type of splint, a grip splint or anything, because of how it is, or sometimes because of the person's behavior. If you have a person who's kind of combative, or they're just not really allowing you to try to get another type of orthotic, which is a little bit more complex, this is a very simple tool. Additionally, the CNA staff or the nursing staff that will need to utilize it, or to make sure, or the caregiver who's helping the resident don it regularly, it's a very simple tool which almost anybody can follow, and it's easier for them to use. When you look at it, it has a section here for the person's name. Depending where you're at a facility, you're allowed to put the name or not. It has also some numbers there. As you can see, you can use these numbers as markers to tell you to document or to use as reference as to how far you can move this down the hand to demonstrate how much it's opening. So if I had somebody on the occupational therapy caseload, I'd probably mark down, where we started from, how far I was able to get the person's hand in, and then as we progress, where I would like to get it to, and obviously you use those markers for that. They're also really good when you're talking to a caregiver or a family member to tell them, okay, when you put it on, go ahead and take it to number 9, and that way they have a reference. Otherwise, they might try to go all the way down, and that person's going to be uncomfortable because remember, this hand it's closed, it's tight, and the more you try to open it, the more pull you're going to feel, and the more uncomfortable it's going to be for them. So this is something that as you do stretch them to a more open position, you do it gradually. I mean, you're talking about weeks, months at times, depending how far you're trying to take that hand. And keeping in mind that as a healthcare professional, you have to make that call as to what's feasible. Again, based on your experience, you have to understand how far you can actually go. Again, for those people who are maybe family members or other caregivers that might be listening in, keep in mind that at some point that tendon and that muscle is going to contract to the point where you're not going to get it back to full length. It's just not going to happen. Some of those extreme cases, they'll do surgical procedures to release a tendon or other items, reattach it. but naturally or stretching wise, it's going to be limited. You know, it's different for me to say that I have somebody here and we're going to get them to a normal looking hand as far as positioning. That's more doable. But once you go to a complete extreme where all the hand flexors are tightened and the finger flexors are tightened to the point that, you know, their maximum flexion range, it's really unlikely that you're going to be able to stretch them all the way to the point of full extension. It's just again, and it all depends on the medical condition, right? B, how long the contracture has been this way, and obviously the severity of it. You know, contracture here, okay, we can probably extend this out, but contracture here, unlikely that you're going to be able to do that. Okay, so again, our goal here is to just get the hand open enough to where hand hygiene can be performed and to where we can get a more open hand to the comfort and the potential range of this individual. So getting back to the carrot stick, it's called a carrot stick because it looks like a carrot stick. No, really. If you notice, there's a little string here, and the string is the key. When you get some of these, sometimes they'll have a little small plastic rod looking thing, and that rod is utilized, I don't have it here with me, sorry, but the rod is utilized to insert it into the hand so that it sticks out on the other side, and then you can loop this into that rod to help pull it through. In my experience, I've been able to work around it a lot. I tend to find that no matter where I'm at, those little rods tend to be lost. They're very small, they get misplaced, they fall, they break, what have you. So what I use, I just use the string itself. So if you have a hand, generally speaking, I really do not recommend that you ever go to any joint and just cold stretch it from the person just being there. Hey, how you doing? And boom. You know, I believe that you should definitely warm up the area. So how you warm it up, it's going to be up to you. So, you know, you could say, for example, if you have a flexor contracture here, I would massage those flexors out, you know, going from the extrinsic wrist flexors and working my way into the intrinsic hand muscles to kind of loosen them up. And then I just kind of slowly try to do what I can to get some movement if possible during that part of that range of motion. And obviously, depending on how much time you have, then it depends how much time you can spend doing that. Keep in mind that a little trick of that is there's a tenodesis grafts that we use with people who have spinal cord injuries. We try to promote that, but the principle of that is pretty handy when you look at hand contractures, because when you have somebody who has a tight hand and you're trying to get in there, if you bring the wrist in a little bit, it'll give you some release, and that's usually something to keep in mind. You know, if you're trying to open the hand on somebody whose contractor is tight to begin with, and you're stretching the wrist back initially, you're actually making that tighter. So you're making your job harder, and you're making it harder on the person. So keep that in mind. Bring the wrist in slightly, which will give you some release, and it'll help you with that, you know, preparation. Other things you can do to prepare, I mean, you could use a small massagers in the area. Some people can use electrical stimulation depending on the precautions. You know, remember that when you're looking at coordination or range of motion issues, you have, or tonicity, high tone issues, you have one side who's dominating, but that means that the antagonist is not performing to their level. Because in order to avoid this, the flexor area, the flexor contractures, my extensors have to be stronger than that and be able to offset that. So sometimes promoting or trying to activate or stimulate the extensors can be beneficial as well. So getting back to the carrot stick, okay? So you have the carrot stick, you're trying to put it in the hand. Like I said, you've warmed up the hand a bit, and you know, some people will do like moist hot packs. Now, again, this is during the treatment. If you're looking at the family member doing this, or the personal caregiver, an aide, they're not probably gonna do all those things because of the time. So, you know, just a quick, you know, massage and getting the hand ready or making sure that they're using the right technique will do. But getting to the next point, you insert it from the thumb side. This is a radial side. And you bring, regardless of the position, you bring the string in there. I'm going to do it on myself. So it's a little bit, so again, usually the hand will be contracted or have some sort of weird tone. Sometimes it'll be fully, sometimes partially. And basically, regardless of the situation, if it's somebody who's partially, you can usually sneak that string in there pretty good. Thread that in there pretty good. If there's somebody who's pretty contracted, then you go one finger at a time. You try to make sure you get out of the thumb, then you sneak it in. And the best way I usually is I'll just kind of softly put it into the palm and work it in. Now, once you get into that section and you have this part out there, it's easy street from here, no matter how bad the contraction is. The main thing that you have to look out for is that you're not going to take this and just yank it, okay? You're dealing with a person here. You're dealing with a tight hand. They're going to be in pain if you do this the wrong way, and they're going to be less likely to wear it, okay? So you let them know, hey, just let me know when you need me, just stop, and you start, kind of pushing it through. For people who are a little bit tighter, it's a little bit harder to go through. I sometimes will use one hand or one finger here to pull, and I'll take my other hand and I'll slowly just kind of turn this as we go. I find it goes in a little bit easier. Once you get the carrot stick where you feel it's going to give a decent stretch, remember, if you go too far and stretch him too much, the person's not going to be able to tolerate it for a long time. So you want to have choose a spot where it's more than what it would be without it, but that's going to be tolerable. And then obviously you'll establish a wear and care schedule with the resident, with the family member, or with the staff members, based on what you're intending for it to be. Obviously, if you can provide a handout, make sure it's written and documented so people can have a reference to it, because nobody's going to remember the numbers, and you're not going to remember the numbers either. So you want to make sure you can be objective about it and be able to utilize that data. And with somebody who's actively in treatment, and you can get an idea. You can even set goals based on these tick marks and say, this is where I would like to get them in 2 weeks or 4 weeks or 6 weeks, depending what it is, the time frame that you're looking at. Obviously, they come in very handy. Now, I've had one experience where I used this on somebody who was cognitively and behaviorally pretty impaired, and because if you notice, it is pretty long, and when you have somebody like that, they tend to want to just snatch it out, or they'll grab and they'll pull to take it off. And one of the things that I did, and it worked for me, and it wasn't too hard to do, for this particular resident, I actually cut this and then I sewed it back up to make it shorter so that it would fit in their hand, but there wouldn't be enough of it to grasp and pull away. And it was very useful in that particular case, because it allowed us to really work on expanding the person's hand a little bit without worrying about the behavior of constantly removing it, and therefore not being able to benefit from it. Again, you'd have to look at your policies and see what, there's probably other things you can do as well. But if you've ever used a carrot stick, or you haven't, please feel free to give me a comment or any questions you might have on this. Obviously, it's not the one-all end-all tool. There's different things, but it's part of the orthotic interventions that you can keep in your toolbox in your brain, so that you can utilize with residents. I found that this is very easy to use, simple for caregivers and families to carry over, and they are washable, because depending on the situation, they can get kind of dirty. So I would always have an extra one available, so as one's getting washed, the other one's handy as well. Well, thank you again for your time, and look forward to any comments. Please remember to like, subscribe, and follow me on Instagram as well. Have a good day.